The Moria artificial anterior chamber is really an elegant way to prepare the donor for posterior grafting procedures. What we're doing here is we have an infusion of balanced salt solution hooked up to the bottom of the Moria artificial anterior chamber. And we have it turned on when we place the tissue on the top of it, but then we turn it off once the air bubbles out from underneath the corneal tissue. Then we assemble the rest of the artificial anterior chamber, and now we're turning the mechanism within it to push the donor cornea up against the portion that locks it in place. So when we do this, we want to make sure that the donor cornea is centered on the center of the artificial anterior chamber, which essentially, when you look down on it, gives you a pupil. And that's real important because that's the center of your cut that's going to be made. And you really want to have your entire resected area be corneal tissue and not sclera. What I routinely do is remove the epithelium from the surface of the donor cornea. We do this for two reasons. One is that the epithelium can be irregular after it's been in tissue storage solution for a while, and it may have a defect just from when the donor was before they were harvested. You might have an area in the palpebral fissure area that's dried out. The other reason is that I want to make it thinner so that we get a deeper resection with the microkeratome. Now, I've made a mark with gentian violet, and this will be a reference mark for after we resect the anterior part of the cornea for placing it back in position. We're now measuring the thickness of the donor cornea, and this will give us an idea of which microkeratome head we want to use so that we end up with a deep dissection that's approximately 100 to 150 microns thick when we actually have the donor tissue. So the thickness I'm referring to for 100 to 150 microns will be the donor tissue used later in the procedure. This is the 300 head of the Moria CV system. After inspecting the blade, we're going to engage it in the tract, and we're now making the resection across the cornea. As you can see, it makes a nice, smooth, even resection. The resected piece of cornea has now been removed from the microkeratome. I'm placing it back on the surface of the corneal tissue, and we're going to line it up to match with the gentian violet mark that was placed earlier. Once the corneal cap is in position, I'm going to use Wexel sponges to dry the gutter around the edge, just like you would with any free LASIK flap. Make sure the alignment is symmetrical. And once the cap is in position, I'm going to take gentian violet once again and mark the very center of the resection. Essentially here, the center of the pupil. And we'll use this mark in a little bit to line it up with the cutting block. Now we've turned the infusion back on at this point so that when we start to disassemble the artificial anterior chamber, we don't want it to collapse and actually create suction that could pull the endothelium back down against metal in the artificial anterior chamber. So you'll see that as we lift this up, there'll be some fluid flow. And then once we get air behind the cornea, we can turn off the infusion. We're now going to remove the donor cornea with the cap on the surface and line it up with the center of the cutting block. Now once it's lined up and in position, we'll put some more tissue storage solution on top of the endothelium to help protect it, and we'll also hook up the wall suction to the block to help fixate the donor cornea in place. But we don't hook up the wall suction until we're sure that the donor cornea is in the proper position. This is a very elegant system for creating a very centered cut of the donor, which is very important when we have made a resection. It's only about 1 to 2 millimeters in diameter larger than what we're going to actually harvest and put in the patient's eye.